All right. Um, I think everyone probably remembers who I am from yesterday, but I'm Cara Poland. I'm a board certified and fellowship trained addiction medicine specialist in Grand Rapids, Michigan. And we are going to talk a little bit more about trauma and isolation, and then move into some discussion around advocacy and how we've been able to make some changes in the state of Michigan. So trauma actually physically changes the structure of the brain. It causes a decrease in resiliency that is that it happens after chronic trauma. And when this happens earlier in childhood, it actually changes the brain structure during that childhood development. And we know that this can have lifelong effects, and this can impact this does impact the way that the fight or flight response works. And so if that fight or flight response is chronically activated during childhood because the caregivers in your life aren't able to perform those functions or aren't safe places, then that chronic activation of the fight or flight response leads to chronically elevated things like cortisol, our stress hormone, and that impacts the size and the shape of things like our amygdala and hippocampus in the brain. So when somebody experiences a trauma, when there is, the point of this was if we were about to be attacked by a bear, how are we going to adapt to combat that? When the fight or flight response is activated, our blood flow actually decreases to the thinking areas of our brain, and we shut down things like digestion and non-essential tasks in order to convert all of our energy out into our muscles and our periphery, into our non-thinking areas of the brain, because we didn't really want rational thought to be possible, because this is, there's a bear, it's coming at me in the woods, and I need to react. I don't have time to think, should I stop and fight the bear? Should I lay down and play dead against the bear? Should I run away from the bear? We didn't have the time to think. We don't have the time to make that rational thought. We need to physically react. This is also kind of what happens when we hear about the superhuman strength that comes, my child is trapped underneath the wheel of a car, and I lift the car up and I get my child and I sweep my child out. There is no way that the 5 foot, 110-pound Cara Poland would be able to lift a car up without something happening to cause superhuman strength. That all is our fight or flight response. But again, when that's chronically activated, it impacts how our brain develops. It impacts our psychological functioning. It impacts our physical health. It impacts our relationships and how we interact with others. And it is a significant predictor of substance use. Research has shown that overactivation of the fight or flight response system can cause our natural alarm systems to no longer function properly. So this is the person who comes into the emergency room, and just by the stimulus of an emergency room, it's not exactly a quiet, calm, nurturing environment in our emergency rooms. There's bright fluorescent lights, there's lots of noises, there's beeping machines, there's people putting blood pressure cuffs on you if it's an emergency. There might be 5 or 6 people surrounding me all at once. And that's scary. That's scary for me. And I don't have a huge history of trauma. That's scary for a child. That's scary for anyone who comes in. When we have somebody who comes in who has a history of trauma and is more likely to unconsciously perceive that as a threat, it's not a wonder that they may react in less healthy ways. We create, and then over time, if somebody is involved in a stress environment chronically, then normal stress can be perceived as a greater threat. It affects that person's sense of safety. So they might not feel safe in an environment where we're trying to create safety. It can result in emotional numbing and avoidance, and a diminished capacity to trust others. And all of that can come together into what we maybe call or perceive as a difficult patient. It's really that they may have this history that makes it harder for them to adapt to that environment, to the environment of a healthcare system. I know for myself, I have routine healthcare maintenance for my children, right? I take them to see the pediatrician once a year. My son has no underlying medical issues. My daughter has a well-controlled seizure disorder, and she hasn't had a seizure in 2 years. They've been talking about tapering her medications, which gives me heart palpitations. But when I walk into the pediatrician's office with my 2 generally healthy children, I get nervous. What if they find something? What if there's something I've missed as the parent? As a doctor parent, I mean, I'm not a pediatrician, but I'm a doctor. Shouldn't I know something's wrong with my kids? What if they find something? Or like what happened last year when they were talking about scooter and bike safety, and the pediatrician asked my daughter, what does she wear when she rides her scooter? And my daughter deadpanned and said shoes, because wearing a helmet in my family is non-negotiable, but my daughter kept trying to ride her scooter with no shoes. And so we were having a lot of conversations about how important shoes are with our scooter. And so my daughter was like, shoes. And the pediatrician was like, anything else? And my daughter was like, nope, just shoes. I have to wear shoes. That's what mama says. I have to wear shoes. And, after a few minutes, she was like, oh yeah, a helmet. I got to wear a helmet too. But I had that moment of like my fight or flight response was activated. I got a little sweaty. I was like, oh my gosh, this pediatrician who's my colleague who I work with, she's going to think my kid doesn't wear, like, I know she's asking about helmets and I just want to blurt it out, but I can't. Right. And so if I walk into the healthcare system and I'm having these feelings and these anxieties, then certainly somebody who doesn't know the healthcare system as well, who doesn't have the resources that I have, is also going to have maybe some elevated fight or flight response. And depending on what their background is, they might have a reaction to the environment that seems maladaptive or confrontational to me and my staff, when really we should be able to expect that type of behavior. This is not a course on providing trauma-informed care, so I'm not going to go into trauma-informed care, but I do want to put a plug in that if you haven't had training or looked into trauma-informed care, I think approaching all patients, just all humans in general, from a trauma-informed perspective can help us as healthcare providers be more open and understanding of what's going on with those individuals. I'm going to pivot at this point and start talking about addiction in the community. Trauma has a huge part of that. We know that people who have had trauma in their past often can feel isolated from other humans, often have difficulty making those human connections. And so one form of trauma for individuals can be isolation. I'm going to talk about some experiments that were done in rats back in the 1980s in Vancouver by a team led by Dr. Bruce Alexander. If you Google search rat park cartoon, you can see kind of all of these studies that were done over time in his lab, and I think it's fascinating. I'm not going to go through the whole history, but that's a resource for people in general. And so what Dr. Alexander did was he put rats alone in a cage, and he gave them the choice between 2 different water bottles. One water bottle had water in it, unadulterated, and one had water in it with cocaine added to it. And in subsequent experiments, he did morphine and other substances of misuse. And the rats used the drug water until they overdosed and died. They used the cocaine to the exclusion of eating. They used the cocaine water instead of the plain water. And this is part of where we got the just say no, that the concept that the exposure to cocaine would automatically lead that rat to use the cocaine to the exclusion of food until they either died of an overdose or died of starvation. And so And so we said, okay, that we're going to translate to humans, and it's clearly exposure to substances does something that causes them to neglect other basic functions. And we talked yesterday about how in the neurobiology of addiction, that the pleasure reward center also responds to simple sugars. But as Andy pointed out later on yesterday, we also talked about how that exposure results in a dopamine surge, and that drive to use drugs is much stronger than the drive even for food. And that certainly plays a role here. So Dr. Alexander said, well, one of the reasons we use rats as a human analog is because rats are social creatures, and they have some similarities to humans along kind of the social spectrum. And so maybe there's something about putting the rats in isolation that's kind of confounding or complicating my experiment. So he created and put the rats in a cardboard box that he called Rat Park. And Rat Park had toys and food and tunnels and other rats to play with and make families with and have sex with and get all that kind of good rat socialization in there. And so he gave those rats the same choice between water that was drugged and water that was not. And well, there were some rats that did use the kind of adulterated water. The vast majority of the rats tried it, and then preferentially went to the plain water. There was something about that community that brought those rats away from the substances of misuse and engaged them, and they didn't want to use it as much. So they kind of started avoiding for the most part, the morphine. Now there was still morphine use. There were still rats who preferentially went to the morphine compared to other rats. But it was not everyone. It was not kind of a society that was disrupted. Meanwhile, during the Vietnam War and to date, actually, the VA administration is the largest provider of substance use care in the United States. So part of this comes from the fact that during the Vietnam War, about 20% of soldiers used heroin while on duty. I cannot think of a kind of more scary, isolating experience than being in a war zone, right? You don't know what you may, if you'll live to see the next day. You don't have contact on a regular basis with your loved ones. You are taken away from kind of your community in many regards and put in kind of this isolation community. Yes, you have the other soldiers around you, but they're also in kind of this uncertainty and this uncertain environment as well. So when we were starting to bring soldiers back, there was a lot of concern around reintegration, given the clear addiction that the soldiers, that 20% of these soldiers had. But what we found was that 95% of the addicted soldiers discontinued use after returning home. And so I like to think about that as a little bit like an analog of the Rat Park studies. We had this idea that when we put these humans into isolation and they consumed all of this heroin, that when they came back, they would have difficulty, but being back into loving relationships, back with their family, back in a community that cared for them, and where they weren't, at threat of an ambush or bombing or what have you, on their threats to their physical safety, 95% of them discontinued use without treatment of any sort. So it was remarkable. So meanwhile, let's talk about back in Rat Park. Bruce Alexander, the next stage was he took rats and he put them in a cage in isolation for 57 days, like the first experiment, because that's about how long it takes to get a rat good and physically dependent and showing some of the signs of a substance use disorder. And then he took those rats and he put them back into Rat Park with other rats that hadn't been exposed. And those rats went through withdrawal, but many of them recovered. Many of them stopped using or avoided the morphine. Now, the rate of morphine consumption was still higher than in the Rat Park, where they had never been previously exposed to morphine, but it was lower than it would have been otherwise. So the opposite of addiction is human connectedness. The opposite of addiction is community. And what you're doing is you're trying to create a safe place in your community for persons with a substance use disorder to come and start on that path of treatment. And that is so powerful and so important. So people who are prescribed short-term monitored amounts of opioids for injuries do not necessarily become addicted to heroin. We know that on all comers, regardless of what kind of surgery they have, 6% of them will continue to be on opioids 6 months after surgery. And that includes, it's not different for major or minor surgeries, it just is. So what are some of the possible contributing factors to that exposure leading to a problem? Are there social markers that increase risk? How does isolation play a role? I've been talking about this for years. In the United States, our unit is the individual. If you work hard enough, if you study hard enough, it's the American dream, you can become what you want to become. Now, I was very fortunate, and I know it. I was born in the right zip code. I had opportunities that other people didn't have just based on what hospital I was born in, what zip code I went home to. So it's not just about the individual dream, the individual working hard enough. If we look at European countries, the unit is the family. We see more multi-generational families. We see more multi-generational homes. We see more focus on how do I support my family? How do I support my elderly relatives as they need that help, and not just this kind of focus on, let me get my kids out so that I can enjoy my retirement that we sort of not always, but sort of see in the United States. And if we look at Southeast Asian communities and we look at Asian communities, the unit is the community. And how does that impact the United States being consuming over 80% of the morphine, of the hydromorphine in the world? How are those related? Are they not? I don't know. But what are some of the mitigating strategies, and how can we continue to form community and reduce isolation? We have this culture that is very connected electronically. And again, I've been talking about this for 10 years, but how much more pertinent is this today? Again, I took out some of my slides because I had way too many. But Andy mentioned earlier yesterday that in some of the data slides that he shared, that we saw the highest increase in overdose deaths in the last 40 years in 2020. How much did isolation, which I'm not arguing that we should not have done. Please don't get me wrong. We needed to do isolation and we needed to do those mitigation strategies for COVID. But what impact did that have on addiction? And as we look at opening up our communities, as we look at what does the world look like, as COVID becomes what we presume to be endemic in our community, how can we make sure that if we do need to continue to have shutdowns, if we do need to continue to close things off, what are some protective factors we can put into our communities? What are some safe spaces, both electronically and physically when possible? We know that children are experiencing a burgeon in bullying, in part because there's not an escape, right? They're on TikTok, they're on Snapchat. I don't know what else they're on. My kids aren't quite old enough for that, and I'm too old to know all the cool stuff. But they're on social media platforms in the evenings. Back in the old days when I was a kid, we would come home and there'd be a separation from after school till the next morning to be in hopefully an environment where I was free from bullying in school, free from some of those social pressures. And now our children don't have as much of that separation. What impact is that? What impact is that having on their development and on their growth? And how do we balance the need for that social connectedness and that social connection as we go through childhood and adolescence, with keeping our children kind of safe and helping them explore what are safe spaces for them? So it's it's not, I don't have answers. These are a lot of questions, but we do know that humans have a need to bond and form connections. And if we don't have those, we will be like the rats in isolation. We will look to other things that will give us satisfaction. So the opposite of addiction is human connection. And I'll end this portion with a quote from Dr. Alexander. For too long, we've talked exclusively about individual recovery from addiction. We need to talk about social recovery, how we all recover together from the sickness of isolation that is sinking on us like a thick fog. And this quote is years and years old. This isn't COVID related. It's been going, this kind of thought process has been happening for a long time. So as you create these safe spaces in your emergency rooms, know that the impact that you're having by creating that starting point, by helping your community move forward and treating persons with addiction is going to have a broader impact than what you see. I kind of joked around earlier that this presentation is a little bit of a potpourri. So we're going to move into special populations because that seems really related to isolation. So we're going to start with pregnancy. This is kind of my baby. I mentioned yesterday that this is my clinical space. I exclusively work with pregnant people with a substance use disorder. We're going to speak specifically about opioids given the nature of this conversation, but 5 to 10% of pregnancies are facing an opioid use disorder, and 8 out of 10 women who detox off opioids while pregnant will return to use within 1 month, which is why medication to treat an opioid use disorder in pregnancy is so important. As we've seen maternal opioid use rise, we have seen the rates of neonatal abstinence syndrome rise as well. It's important to know that opioid withdrawal in a neonate is a time-limited disease course. Babies are not born addicted; they are born physically dependent on opioids, and as they go through withdrawal from opioids, a lot of those risks will be mitigated. And as we monitor these children after the pregnancy, we have some data going out to about 10 years now. Babies born to moms who have been on short-acting opioids are more likely to have negative effects longitudinally in terms of behavioral health and particularly ADHD concerns. But children born to moms on medication for opioid use disorder have lower risk of that. So it's not as one size fits all as we'd like it to be in terms of opioids. And both the American Society of Addiction Medicine as well as the American College of Gynecology recommend that the best practice for the care of pregnant women with an opioid use disorder does incorporate medications, either buprenorphine or methadone. These medications prevent withdrawal, which can be a risk for the neonate, particularly in the 3rd trimester, as their nervous system is developing. It reduces cravings, and naltrexone is not commonly used in pregnancy. It is in the same risk category as both methadone and buprenorphine. I don't think you'd be starting that in the emergency room on a pregnant person, so I'm not going to go into my soliloquy about that. So we'll just keep moving right along now. Okay, so let's talk about adolescents. Adolescents are often a population that people are like, I don't know what to do with them. I want to look at, this is a study that's done out of the University of Michigan called Monitoring the Future. In this table, we're looking at 8th and 12th graders who report using specific substances in the past year, the past month, and for cigarettes and marijuana and alcohol daily. The results in red represent a significant decrease in prevalence from the previous years. As you can see, the increases are mostly in, oops, I just clicked forward by mistake, in vaping and cigarettes. The decreases in vaping flavoring and in cigarette use appear to be good news, but the concern is that many of these youth may have moved on to vaping actual substances like nicotine and marijuana. We also see an alarming increase in daily marijuana smoking amongst 8th and 10th graders. And Amongst 12th graders, more than 40% of are vaping, almost 40% are smoking marijuana. Of those 12th graders that are engaging in substance use, more than 40% are vaping, almost 40% are smoking marijuana, and 30% are drinking alcohol, which is really staggering when we think about the fact that these are children and adolescents. If we look at the illicit drug use has been steady amongst 12th graders since about 1997, with 38% of 12th graders reporting past year use of any illicit substance. And that rate falls to about 12% when we exclude marijuana. This figure on the right here indicates that marijuana use makes up most of the use of illicit substances, which seems to be true. It's noteworthy that more than 35% of 12th graders in the survey report marijuana use in the past year, and that means more than 1 in 3 12th graders has used marijuana within the last year. I mentioned yesterday that we often think of addiction and substance use disorder as a disease of development and it often starts in adolescence. This slide just shows that the opioid epidemic was not confined to adults. Rates of prescription opioid misuse amongst teens reached peak levels in the early 2000s when more than 10% of 12th graders reported past year misuse of Vicodin. But both past year misuse of Vicodin and OxyContin have dropped significantly over the years since then in all 3 grades and currently stand at less than 2%, which is certainly a vast improvement from where we were previously. And just as a side note, in this study, misuse refers to using prescription medications that are not one's own prescription or using one's own prescription in a manner inconsistent with its labeling, like using more than prescribed, more often than prescribed, crushing a pill, snorting it, smoking powder, any of those types of things. Pharmacotherapy has been shown to be efficacious in adolescents as well. However, it's important to note that for many of them, they are not FDA approved under 18. So they're sometimes used off-label in older adolescents. But buprenorphine is allowed in persons age 16 and over. Methadone cannot be used off-label in individuals under 18 years old by federal regulations. So methadone is not available to people under the age of 18. So really we have buprenorphine as an option for adolescents with an opioid use disorder, as well as naltrexone. But again, I don't think you'll be starting naltrexone in the emergency room because they have to be opioid free for 7 to 10 days to be able to start that medication, which just I think is outside of scope of this discussion. Let's talk about substance use disorders in older adults. Substance use disorders in general, the prevalence decreases with age. Men tend to have higher rates of substance use disorders than women during adult life from age 18 to 90. But don't worry, over the recent years, women have been catching up. Men have not been decreasing. It's just that women are getting better at using substances. Many older adults, like younger adults, have co-occurring substance use disorders. There seems to be an attrition rate where when we get into later geriatric age groups, that they tend to have more mild substance use disorders. It seems as though from the epidemiology that may be because people with more significant substance use disorders die earlier because of a lack of treatment and a lack of support for them. And a lot of times substance use, particularly around alcohol, is very normalized as we get into our retirement ages. We don't need to get up in the morning. It's okay to have that extra glass of wine on Tuesday night that you may have otherwise said no to historically. We also see age-related changes in alcohol and drug metabolism, increase in chronic illness and an increase in polypharmacy in general that increases the effect and negative health consequences of substance use so they can progress more quickly than a younger cohort. older adults are also at risk of having significant life events like the death of a spouse, or the loss of a, when people retire, there can also be a feeling of a loss of part of the individual's identity that can put people at risk for substance use disorder, particularly with opioid use disorder. Non-medical use of opioids has been growing in this population as well. It may in part be related to drug metabolism. And in fact, there aren't as many resources available specifically for an older adult population, nor has this been as well studied in younger adults. So there have been some cohorts that show that older adults do better in treatment, intend to stay in treatment more than their younger adult counterparts. And we do want to make sure that we offer them medication and treatment as well. We do sometimes have to decrease our maintenance dose of some of these medications in older adults based on drug metabolism. But I don't think that really, you need to get somebody out of withdrawal, and that's going to be your primary concern in an emergency department. And that's more of a longer longitudinal management concern as well. We're going to talk briefly about veterans. We have about 18.8 million veterans living in the United States today, which is about 7.6% of our population. And most veterans actually don't necessarily receive their care from the VA system. There are kind of different algorithms for who is eligible for VA care and who is not, and what's available at a local VA can be variable. Certainly in some of our smaller, more rural areas, there may not be accessibility of a VA. And so veterans can exit the VA system to get care through the Veterans Choice Program, as well as through the VA Mission Act. And there's more information available if people are interested in that. There has been a push over the last decade or so to make community care more accessible for veterans. And we certainly, despite there being a CBOC, a community-based outpatient clinic here in Grand Rapids, we certainly do get a portion of veterans who come seek care with us. It's also helpful if there is a VA in your community. Sometimes they will accept our prescriptions, and the veteran can have their prescription benefit at the VA, and also making sure you're communicating with their VA providers, because oftentimes the VA providers are used to being able to see everything kind of within their EMR, regardless of where that goes for that care. And so sometimes we need to do a little bit of extra reach out to them to make sure that they're aware that we're collaborating on this patient as well. The rates of opioid overdose in the VA population are higher than those in the general population, but the trend is the same as in a non-veteran population as well. Risks for overdose are increased by similar factors as for a non-VA population. We see a lot of co-occurring illness and with mental illness and substance use disorder among veterans, and certainly a higher rate of PTSD in particular. And some people may medicate some of the PTSD symptoms with substance use as well. There are, as in the general population, again, which Andy covered yesterday, treatment gaps in terms of who should receive SUD treatment and who actually does receive SUD treatment, although those gaps are smaller than in the general population. Again, that with the VA being the largest provider of addiction care, they have kind of national guidelines and national standards in terms of how to get veterans into the appropriate level of care for them. And there are resources available for veterans to access as well. And just in summary, we've covered that SUD is more common in veterans with mental health disorders, veterans are vulnerable for substance use disorders and overdose, as well as some of the psychosocial risk factors. And the VA has a lot of resources available. I feel like I could have spoken for an entire hour on any one of these populations, and then infectious diseases is just like Pandora's box to me. So I'm just going to not even scratch the surface. We all know that often what brings somebody to an emergency room with a substance use disorder is an infectious disease complication of their substance use disorder. They have an abscess that won't heal, they have a fever, they have endocarditis, they have osteomyelitis, and they also live in an environment, as Andy mentioned a couple times yesterday, and that if somebody lives in a drug house, it's going to be harder for them to stay in treatment. If somebody doesn't, as Ariana mentioned multiple times yesterday as well, as somebody doesn't have the community resources to keep them safe, like a safe place to live and a safe place and access to food and access to, shelter, it is going to be harder for them to engage in treatment in what we perceive as a meaningful way. So treatment is often interrupted when it comes to their infectious disease complications of a substance use disorder. And in one of the videos we watched yesterday, we heard the patient who said, the heart surgeon came in and said, tough luck, I'm not fixing your valve a second time. And essentially, that's more or less a death sentence for you. And there's nothing I'm going to do about that. So we do often in our environments need to combat some of that as well. And the bottom line is, when you're treating substance use related infections, we need to include the treatment of the substance use disorder and focus on source control. Infectious diseases can pretty much hit any of the following, any system in the body. The ones that have asterisks next to them have specific Infectious Disease Society of Infectious Disease Society of America guidelines available for how to treat them in persons with a substance use disorder. Infections are a frequent complication of substance use for a broad variety of reasons, route of administration and associated behavior being large contributors. Substance use may complicate the diagnosis of many infections, and it's important to maintain a high index of suspicion for many complications. We talked yesterday about cotton fevers. We still need to investigate those. And, we shouldn't just attribute it to cotton fever. We need to kind of do a full workup and look for some of these for some of these other complications as well. Many of these infections are preventable. We had some talks yesterday as well on harm reduction and the importance of things like syringe exchange and safe injection supplies or safe smoking supplies. And we spend we spend a lot of money in the healthcare system treating infections that would be preventable with stronger and broader harm reduction strategies in place. So in general, infections, a frequent complication of substance use. There are a lot of reasons for this, and we can prevent many of this through stronger social structures. And now we're going to move into kind of the next topic. I told you guys it